Welcome, everyone. Thank you for joining us today. This is a special Can Do MS webinar Wednesday on a Tuesday to make it extra special. We're focusing on the topic of understanding invisible symptoms of MS. My name is Paige Kennan. I'm a senior programs manager at Can Do Multiple Sclerosis, and I'll be your moderator today. Can Do MS is excited to partner with the Texas MS Consortium to offer two special webinars this month geared towards the Texas community. This is the second of the two webinars. And not to worry if you're not living in Texas, the information provided throughout this webinar is going to be very relevant to the general MS population as well. As always, I want to take a quick moment to thank our generous sponsors for supporting this special webinar series. Thank you to the Kathleen C. Moore Foundation and Novartis. Both of our speakers for this webinar are Texas healthcare professionals. We have Heather Mowry, who is a doctor of physical therapy, as well as neurologist Lauren Tardo. Heather, Lauren, welcome, and thank you for joining us today. Lauren is going to get us started.
Hi, good evening. Thanks for the introduction, Paige. Heather and I are excited to be here. As Paige said, we're both in Texas, and so excited to be chatting with the MS community today, as well as everyone outside of Texas. As Paige said, a lot of this is very relevant. All of it is actually very relevant to anyone really living with MS. And so for tonight, our learning objectives, so really the goals are to recognize and understand the impact of invisible symptoms in multiple sclerosis. We also want to develop some effective strategies for managing these, and then also talk about a few communication strategies to potentially kind of address these with caregivers, friends, or other people that may be in your life. And so the big purpose of today is, to talk about the invisible symptoms of MS. And so I expect that many of you are living with MS, or someone living with MS, you're a care partner. And so with MS, a lot of the symptoms we can see in terms of if it's physical mobility, something that is visible to the eye, but really a lot of the symptoms are also under the surface and really kind of fall into this category that we label invisible symptoms of MS. And if you're not the person experiencing, the symptoms, they're really invisible to everyone around you, your children, your spouse, your parents, your coworkers. And so it can be very frustrating, I find, for patients to live with these because people can't see them. And so the iceberg is a great analogy of this because there's so much under the surface that MS patients experience. And so that's really what we're going to dive in today. And so I'm going to hand it to Heather, and I think Heather's going to start us off with MS fatigue.
Yes, thank you. So I think this slide resonates with the poll where it says 90% or more of people living with MS experience fatigue, and that is definitely ringing true based on your poll results. And I think this is true for both Lauren and I and our clinical practices. And mine specifically, weakness and fatigue are the reasons that I'm seeing patients in my physical therapy practice, and it's very commonly reported among this population. So the take-home message here is that fatigue begins with identifying all the factors that contribute to it and then tackling them one by one. So we'll kind of talk about the different factors that contribute to fatigue and maybe some strategies that we'll put through this slide deck and hopefully some things that you can take home that are tangible to start working toward. First and foremost, I always say, don't sleep on sleep. Again, sleep is so important. You're going to see sleep mentioned on nearly every slide in this presentation because if your sleep is not managed well, then your day-to-day function will not be managed well. It's very important to figure out why you have disrupted or poor sleep. Is it something addressable like too much screen time? I know I'm guilty of this. I look at my phone right until I go to sleep, and I know that can delay my time to fall asleep. Other things that might be related to your disrupted sleep could be your MS symptoms. It could be bladder urgency, muscle spasms. You may have chronic pain that prevents you from sleeping comfortably. And then even more importantly, some medically addressable reasons that you might be having sleep disruption could be related to sleep apnea or restless leg syndrome, and that might require deeper looking into it with your physicians and your other medical providers. So it's really important to kind of build your team around you to really address this condition holistically. Another important thing is that extra exertion required for day-to-day activities can really make you feel fatigued. This might be something as simple as brushing your teeth, preparing a meal, standing and preparing that meal. It might be getting dressed. Those can all be exhausting to you. And those are those deep layered, deep in the iceberg symptoms that your family and friends may not be able to really understand why you're feeling so tired because you simply put on your clothes. So it's really important to note why you're having this fatigue. Another important message is heat sensitivity, which we'll get into a little bit later on, but it's important to know that heat can temporarily worsen your MS symptoms. It will not necessarily cause a progression of your MS, but heat sensitivity can definitely be a contributing factor. And there's a lot of tips and strategies that you can use to manage heat, especially in Texas or any state or anywhere you live that is hot and humid. We're not dealing with those issues right now. However, Texas is hot most months of the year, so this applies to many people. Another one that I talk to a lot of my patients about is muscle fatigue, and this kind of goes hand in hand with daily exertion of your day-to-day activities. So muscle fatigue requires you to use extra energy to move around. So if you're having muscle fatigue, it's important to talk to your provider, usually your rehabilitation provider, about ways to make your movement more efficient so it can work to your benefit. And then another one that is important to talk about is depression and other mood changes. It's really easy to get stuck in a vicious cycle if you do not address your mood or depression or any other cognitive emotional symptoms that you may be experiencing. Depression can lead to fatigue, and then that can amplify your feelings of depression and so on. And so you get stuck in this loop. So please talk to your provider about it if you're experiencing these symptoms, because if it's not the right provider in the moment, they can get you to the right provider to address this. And in the bottom of the slide, you'll see there that fatigue is common in care partners. So a lot of these strategies that we're going to talk about today can be shared with your care partners, whether they're on the call or you can take this information to them. Care partners also have mood changes and fatigue. And then on the right side of the, oh, sorry, page, on the right side of the slide, I just want to mention briefly that medication side effects can and will happen. So commonly, medications that you need to take for spasms or spasticity can cause drowsiness and lethargy. So it's really important to address your medication as well. And then finally, a term that I actually learned by working with Can Do MS is called lassitude, and we consider this a primary MS fatigue. And what we mean by that is this overpowering feeling of tiredness in the body that can be physical or cognitive. It is very different than a standard type of fatigue that you have from a long, stressful day. This is an MS-specific fatigue that can affect your mind or body or both at the same time. And then we're going to talk about some strategies to manage fatigue. So we all know that fatigue exists and a lot of you experience it, but what can I do about it? Well, first and foremost, to manage cognitive fatigue, something that you might consider would be cognitive rehabilitation strategies that can help with brain fog, memory loss, word finding issues. Some people don't know this, but speech and language pathologists are very well versed and educated in cognitive rehab. They are not just limited to speech and language difficulties. So if you can find a good speech and language pathologist, hold on to them because they can really help give you some tips and tricks for cognitive strategies. Again, adequate sleep. We have sleep on here a couple of times threading through. So take home message, don't sleep on sleep. Figure out the underlying reason that you're not sleeping well and manage and address it. And then again, addressing your mood issues if you are having mood issues, even if you don't know if you're having mood issues. It might be good to take a test or have a screening by your provider to really figure out if that might be an underlying cause. How do we manage lassitude? This is that physical cognitive fatigue that's really directly related to MS. I know it's hard to hear you need to exercise and move when that's the last thing that you want to do, but movement is medicine. Number one quote I learned in PT school is motion is lotion. I had a professor that used to always say, motion is lotion. You have to move your body. If you rest, you rust. So if all you can muster up energy-wise for the day is laying down, then let's learn and do some laying down exercises that you can at least get your joints and your muscles moving and working for you. The 4 Ps is also something that I learned by working with Can Do, and I think this is a really good strategy to remember. The 4 Ps are planning, prioritizing, pacing, and positioning. And so what we mean by planning is that you want to plan your days so that you get the most challenging tasks done when you have the most energy. So if you need to write it or do a diary or use a smart app in your phone, that is totally fine, but plan out your day ahead so you have no surprises. The next one is pace. Pace yourself. And I always tell my patients, when you have good days, don't take too much advantage of those good days. Don't push yourself to get everything done, because what will happen is you will pay for it day 2, day 3, and you'll be very confused as to why you're not feeling well because you just had a great day. And it may have been that you just did a little too much when you were feeling well. So we got to disperse those pockets of energy to work to your advantage. Now, the other thing that you want to do is prioritize. Think about what needs to get done today or this week, and then identify what can wait. Identify what or who can help you with whatever that you need to get done. If you need help, definitely ask. It's important to prioritize things that need to be done on a day-to-day basis. And the last one is position. And what we mean by position yourself, we mean you can sit for tasks like showering or preparing a meal so you're not maximizing your standing efficiency. You might use a motorized cart at the grocery store. If you still like to shop in the grocery store and not do the parking and then bring it out to you, consider using the electric scooters. Some patients say they actually walk better behind a basket because it's not unlike a walker. So you use the equipment that's available to you to manage your fatigue on a day-to-day basis. And then cooling devices, it's probably one of the number one things I recommend in my clinical practice. I really talk a lot about concurrent cooling, which is cooling while you're exercising, but I also talk about pre and post cooling. It's important to cool yourself down before you get your heart rate up and starting to exercise. It's also important to cool down after you exercise so you can get to your baseline temperature and you don't feel those effects of fatigue as quickly. And then again, medication, it's important and it can be a great tool for managing your condition, but it's really important to know that it's an adjunct to movement and exercise, and it's not a substitute for behavioral strategies. And then lastly, addressing symptoms and other factors associated with sleep are also very important. So if you're having poor sleep, please tell your medical provider, because if it's related to bladder problems, you might need to see a urologist. If it's related to pain, you might need to see a pain management physician or talk about physical and medicinal strategies. And then if it's mood or spasms, there's other things that can be the causative reason that you are not sleeping well, and it's very important to get to the bottom of it so you can address it. And then I think the number 2 one, which lines up with this slide that y'all answered on the poll, was pain. Pain in MS is extremely common, and about 80% of persons living with MS experience pain. And it's important to note that there's 2 types of pain. There's musculoskeletal pain and there's neuropathic pain. 2 are addressed in very different ways. Musculoskeletal pain is caused by stress or strain. This may be if you experience hip weakness. If you have hip weakness, guess what has to take up the slack? Something above or below. That might result in knee pain because you're putting too much stress and load on your knee. You might be feeling back pain and not even realize that the source is coming from your hip pain. So it's important to work with your physical therapist, occupational therapist, your personal trainer to address your areas of weakness and see how you can utilize your other muscles to support and not to overproduce and cause you stress and strain. Another one, or another reason you might be experiencing musculoskeletal pain is gait or postural changes. Number 1 being foot drop or drop foot. I see a lot of patients with foot drop, which can also lead to ankle pain, knee pain, hip pain, and if you don't address it, the pain's going to persist. Postural changes that are commonly seen might be what we call a forward trunk lean or a stooped posture because of core weakness. You might experience a shift laterally, left or right, because you have hemiparesis. You have a little bit more weakness on one side. If that's the case, you need to work with your therapist to right up your posture, whether it's using mobility aids to help you maximize your posture and gait. And then incorrect use of mobility aids. A lot of people don't love to hear this, but if you are using a unilateral, a one-sided device, it needs to go on your strong side. If you put the device on your weak side, you tend to lean toward that weak side even more than you should be. So you use the device on the strong side so it advances with your weaker side. It acts as a third leg, a third arm to really help you with mobility. And then another type of pain that is addressable is what we call neuropathic pain. And neuropathic pain is important to understand because this is a disruption of signals between your central nervous system. That's what CNS means. Our central nervous system is our brain and our spine, and that's how it communicates with our limbs. And so this type of pain is really specific to MS in that it usually is caused by damage to the myelin, the protective sheath around your nerves. When patients describe pins and needles, crawling sensations, burning, we know they're describing a neuropathic pain. If you're describing aches and pains and fatigue in your muscles, we know that's musculoskeletal, skeletal, and they are addressed in very different ways. I will say, when you talk to your provider about pain, don't just say, I'm having pain. It's all the time. It never changes. Please use descriptive words, and then that can help us help you figure out how to best address it. Now, the next important slide is, how do I manage the pain that I'm dealing with? If I have musculoskeletal pain, first and foremost, exercise is going to help. Stretching, range of motion, core strengthening, whether on your own or with a partner or with a therapist. Here's the important take-home message. It needs to be customized to you. I really like YouTube videos. I really like exercise training videos. I love to see all of that, but it needs to be customized to your needs and your plan of care. So to the best of the ability that you can get with somebody who is educated in exercise training to customize a program for you, you are going to do yourself so much good. For musculoskeletal pain, again, if you have gait and postural issues, if you're in my clinic and you're sitting in front of me, I'm going to try an ankle brace on you. I'm going to try what we call an ankle foot orthosis, or you might need to trial a Bioness, a neuroprosthetic to help you lift your foot when you walk, and then that can help relieve some of your leg pain. We might need to try anything from a single point cane all the way up to a rolling walker that has handbrakes and a seat so you can take breaks. It's important to be able to try all of these mobility aids to see what's going to work for you the best. Some other modalities that you may or may not have thought of would be some adjunct therapies, massage therapy, acupuncture, electrical stimulation, which is also known as TENS therapy, which TENS can really help with that neuropathic pain that we talked about on the last slide and which I'm going to expand on here. There's actually some literature that's very supportive of acupuncture. And there's another type of needle therapy called dry needling that a therapist has to be certified in, but it goes deeper into the tissue, deeper into the muscle, and it's even more supported in the literature. And bonus, it's covered by insurance. A lot of times massage therapy is not covered by insurance. Neither is electrical stimulation, and sometimes acupuncture if it's bundled with a chiropractor. But dry needling is a great resource if it is the right type of intervention for you. And then for neuropathic pain, little did you know, anti-seizure medicines can be used in an off-label basis for neuropathic pain because a lot of our standard pain medications do not address neuropathic pain. So a lot of those pain medications that we know of in the community are not great for the type of pain that you might be experiencing. So if your provider recommends an anti-seizure med or an antidepressant for your neuropathic pain, there's a reason behind it. It's to address the nerve issue. Other things that you might want to try or consider are behavioral therapy, cognitive behavioral training, and this is a way to reshape your thoughts, emotions, and behaviors around your discomfort. It's a way to come to terms with it, to say, I know I have this pain, I might live with it for a very long time, but if I can do things to reduce it and reshape my mindset, my pain can improve. We might do that through mindfulness. We might do it through meditation, simple honing in on your breathing, thinking about your breath work. A lot of sensory experience therapy can help with that. Thinking about what you can see, feel, touch, and smell. These are strategies that can really help manage your neuropathic pain. And then stress management, again, that's very important. If you're stressed, if you're having mood issues, it will manifest and make your pain feel worse. So it's important to address your stress. And then again, using what we call modalities of ice or heat. If you're somebody who tends to not do well with heat, adding heat can make it worse or exacerbate your symptoms. So you might try ice. Now, I have a good number of patients that say they also don't do well in very cold conditions. And so you may not respond well to ice or very low temperatures, and you might actually do very well with heat. So again, it's important to talk to your provider and figure out, is it neuropathic? Is it musculoskeletal? And then what are the tangible things that I can do about it? And then I am now going to pass it back over to Lauren to talk about mood changes.
Thanks, Heather. That was great. I'm going to take some of those phrases you used into my own practice. Motion is the lotion. That's great.
Yeah.
I'm going to use that. And so I'm going to touch now on MS-related mood changes. These are so common in patients or people living with multiple sclerosis. And really something to realize is that they can occur at any point in the disease course. A lot of times I'll hear that patients will report it as their first symptom in terms of they've had this long-standing depression that really didn't have an explanation. And one thing to realize is there can be many causes for depression or mood changes in general. One thing is it can occur because of changes in the brain and the immune system themselves. So it's a manifestation of the underlying disease process a lot of times, but also it can happen to challenges that you have in life. So MS-related challenges and also just other challenges that are normal parts of life, loss of a loved one, loss of a job, a big move. And so it can be a very normal reaction to big things with life. And it's also extremely important to realize is that mood changes matter. As Heather touched on, they really can impact every aspect of your MS. It is a vicious cycle, as Heather said. It's this, we get on this loop, and a lot of times, each individual symptom is feeding into the next one. And so I often tell my patients is, let's pick one, let's address that one and see if the downstream gets better. And a big one of those is actually mood changes. If we can address the mood changes, a lot of times we'll see some of these other things kind of fall into line and improve a little bit. And another thing to really realize is it can impact relationships with loved ones, with friends, and quality of life. And another big thing that I think we often, at least I often forget, when I'm visiting with a patient is it's important to check on care partners, because care partners can also experience significant mood changes related to watching their loved one go through what they're going through. And so it's important to, as a provider, for me to check on care partners, and also for you to check in on your care partner as well. So I wanted to separate a little bit grief and depression and MS. And so grief is a normal response to losses. A lot of times it manifests as a feeling of loss, a feeling of emptiness, a feeling of sadness, and it's usually a response to something. And so a lot of times, it can be a response to a diagnosis of MS. So many times when I'm meeting a brand new diagnosis, there is a sense of grief in the room and in that conversation of, coming to terms with the new normal, with the loss of mobility or the loss of the ability to do something that you once could. And so grief is very, very normal. I often tell my patients that it's usually temporary. I generally say it's a very steep curve. It's a very and it takes a while to hit the plateau. But once we hit it, things are going to turn around. Once you get into your pace, once you kind of learn what MS means to you, I find that the grief goes away. And then depression is a common symptom of MS. Like I said, it can be a manifestation of the disease itself, of the underlying pathology. And a lot of times with depression, we see actual physical symptoms as part of this. So with depression, you can have sleep and appetite changes. So one can sleep too much or too little. The same thing can happen with appetite changes. People can stop eating or they can eat too much. Patients also a lot of times with depression notice that they have slowed thinking. They may tell me their, cognitive symptoms are worse, which we'll touch on in a minute as well. Or they have behavioral or increased agitation or irritability. And really, the big thing that we have to screen for if a patient is reporting, some of these symptoms is, thoughts of death or suicide or self-harm. Like it's very important to screen for this and check on this, because it's very treatable. The next thing is anxiety and irritability, kind of that short fuse for the irritability. In terms of anxiety, it's equally common, but really receives a little bit less attention than depression does in my clinical practice, and really manifests as, excessive worrying, difficulty sleeping, and restlessness. So there's that sleep again. It's all connected. Tension and irritability. Tension, you may hold tension in your neck, which may manifest as pain and headaches. Patients will tell me, my heart rate feels like it's racing, or I have palpitations, I feel a flutter in my chest, and sometimes that can be a manifestation of anxiety. As a caveat, if you are having heart symptoms, please tell your provider, because we also like to make sure it's not a manifestation of something wrong with the heart. So please tell us that. Patients will also report, feeling of terror or impending doom, or kind of, jumping to worst case scenario. You can't function because you're so crippled by the worst case scenario. Or inability to concentrate. And so this can really kind of feed into cognitive symptoms that we see. And then with irritability, like I said, it's kind of that short fuse. I often hear this from spouses or care partners that they just seem a little bit more on edge, or they snap a little bit more. And this is very common, and can also sometimes be a sign of depression or anxiety, or it can exist on its own. And again, like we mentioned earlier, please check on your care partners. Please remind your team to also check on your care partner. If you've got a concern, let us know, because a lot of times we can get them connected with the right people as well. So how do we manage mood changes in MS? So the biggest thing is to acknowledge the mood changes. I think this is very, very important. It's okay. It's very normal. I think there's a stigma behind mood changes. There's a stigma behind the word depression. And so I think it's very important to acknowledge it, because it's so normal and it's so common in MS, and it's so common outside of MS too. And so acknowledge it, call it what it is, and then talk to your healthcare provider. Most places do regular screening, at least in our practice. Every time you come to the visit, we're doing a screening to kind of see where we're at. And many times some patients will tell me, hey, I scored high. This is what's going on. We shouldn't be concerned about this. Or they'll say, I scored really high. Can we talk about this? And we'll kind of shift the visit to where we spend more time talking about mood than we do some other things. And so it's important to do that screening, ask for the screening if you're not getting it. Other ways we manage it is cognitive behavioral therapy or talk therapy. And so many clinics, not all of them, but many clinics will have a licensed counselor kind of built into it. If they don't, the National MS Society and Can Do as well have lots of resources to connect you with people who are very well versed in multiple sclerosis and the mood changes that come along with it. Medications also. I think medications are important. I often tell my patients doesn't have to be a forever thing, but if we need it, we need it. And as Heather mentioned, with anti-seizure medications being helpful for neuropathic pain, a lot of times the medications we use for depression are also very helpful for neuropathic pain. And so I often tell my patients is let's take two things down with one medication and then kind of reevaluate. The other thing is physical activity, as Heather mentioned. It's so important. Many times my patients don't want to hear it when I tell them, in terms of this is a way to mitigate fatigue and also mood changes, but it really is, and it's really about the consistency. It can't be I did I did this one thing and I don't feel better, so I stop. You've got to stick with it. It takes time. And then also building your social support, building that circle around you, finding community, engaging in with people that you meet at Can Do MS. Things like that are huge in terms of managing mood. Don't be isolated because you're not alone. And then want to shift gears a little bit and talk about cognitive changes in multiple sclerosis. And so this is also very, very common. I think the number is probably higher than this, but at least 65% of people living with MS will experience cognitive changes. I think this number is closer to everyone living with MS will experience some sort of cognitive changes. There's a scale, not to scare anyone, but I think at some point there's something that patients generally report to me. This can occur independent of physical disability. So sometimes my patients will look really well from a physical exam standpoint, but they will have severe cognitive manifestations. So the two don't necessarily go hand in hand, and one doesn't necessarily mean the other is going to match it in terms of severity. In terms of the most common changes, a big one is information processing. Another one is learning and memory, specifically learning new tasks. Attention and concentration is one, and this kind of feeds back into fatigue as well, because that feeds into this. Often what I hear from my patients is, I get lost in conversation. And a big thing that I hear is that, if multiple conversations are going on at once or multiple things are going on in the background, they really struggle with that one conversation. I see that someone put multitasking. Yes, that falls into attention and concentration, as well as trying to hold on to multiple tasks at once. Sometimes patients will lose a task. Executive functioning can be impaired sometimes. And this is, when we say this, we mean like planning, making decisions, problem solving. And so sometimes it can be very difficult to work through more complex things. And then a big one is word finding. Many patients will tell me, it's right on the tip of my tongue. I can describe the word, but I can't tell you the word. Or forgetting names. That's another common one that I think kind of goes hand in hand with word finding. And so how do we manage the cognitive changes in multiple sclerosis? So again, early and ongoing screening. And so at diagnosis, this is really something that we need to be talking about in our visits. Are you having any cognitive symptoms? What are they? And then also reevaluating it. If someone gives me concerning symptoms of cognitive changes, many times we'll go on to more of an in-depth evaluation. So what I can do in my office is a very brief, what we call it a mini mental status exam, or there's different variations of that just to kind of get a sense for where we're at. But a lot of times that doesn't give me the full picture. And so if we find something on that, what we generally do is we partner up with our neuropsychologist and we'll get an in-depth evaluation. And the in-depth evaluation usually is like a 4 to 6 hour day. It's a lot. I had to watch it once when I was in training, and it is a lot. And really the goal of it is to try to parse out where are you strong and where are you weak, and does it fit a specific pattern? And then once we see that, in terms of how do we manage this, as Heather mentioned, speech and language pathologists, they're amazing. They are well trained in ways to compensate for some of this stuff. And so unfortunately, there's not, a great medication that we can give to, reverse the cognitive changes that we see in MS, but there's ways to compensate. If you're a list person, make a list. Everyone's phone now, there's ways to set reminders, there's ways to set to-do list. And so that is huge. And then another thing is lifestyle. And so these things go hand in hand with pretty much every symptom in MS, and also just a healthy lifestyle in general, is having a healthy and balanced diet. This is huge. This is huge for every aspect of MS. This is also huge for just health in general. Physical activity, here it is again. It's so important. Stress management. So if a patient, has depression, anxiety, they're going through some of those things, and or stress, let's manage that. Let's see if we tackle that, does it get better? A lot of times it does. And whenever we do our in-depth evaluations with neuropsychologists, sometimes they'll even say in their evaluation, patient endorsed depressive symptoms. we should try focusing on that, because many of these things may be actually a result of the depression, not true cognitive changes. And so it's really important to work on that. And then the other thing is mental stimulation. I have many patients who tell me that they stay cognitively active by doing puzzles. They do Wordle. I think my patient yesterday told me she was up to date on her Wordle and gave me some crazy statistic, and it was crazy. She was like, "That's how I keep my vocabulary. My mind active." And so finding things like that you enjoy, that also stimulate your mind, can be extremely beneficial. So how do we talk about our invisible symptoms? As we mentioned earlier, they're invisible, right? We call them invisible symptoms for a reason, because people can't see them. People can't experience what you're experiencing. No one can read your mind. No one can read what you're feeling. And so it's really important to come up with a strategy to talk about this. And so one of the first things you should do is really be prepared to describe how this affects you. And so, if your biggest symptom is fatigue, being able to know when it's most likely going to occur, so you can let a loved one know. Let people know how it changes from day to day, or even really hour to hour. Many times my patients will tell me I wake up feeling great, and then I hit a wall and think the whole day just goes south from there. It's important to have a plan B for your plan A's, just in case, and making sure your friends or colleagues know that it's really not about them. This is about you protecting your health and your well-being. I always tell my patients, give yourself some grace. If you need to cancel, cancel. It's so important to make you a priority. And then we did this talk a couple years ago, and one of the things that came up was like coming up with a signal for like your partner. If you're, at a gathering and you're just you're done, thumbs up, thumbs down, or you can do something subtle, like come up with a signal, like the ear tap means it's time to go. Or some phrases like red, yellow, green light. So just a way to, easily communicate it without having to, deep dive into it. It's like, it's time to go. I've kind of hit my limit. And then also a lot of these organizations can do, National MS Society, have reading materials that are directed towards care partners to others to kind of inform them and help them understand what you're feeling. And so educate them. And so I think that's a huge piece of it. Excuse me. And then I'll hand it off to Heather to kind of talk about some Texas specific thing. I know there's a lot of people not from Texas, but these still apply because it's not just hot in Texas.
Absolutely. So I was going to say Texas and any other state that gets warm and humid. So a lot of states this could apply to. So first and foremost, simply exercising, taking a hot shower or bath, that can affect your MS symptoms. But it's really important to know that heat only generally worsens symptoms temporarily. It does not cause more disease activity or additional damage. It is very temporary. So if you have that in mind, it can reduce your stress response, which can, in result, cause higher body temperature. These symptoms will usually remit or go away once you're able to cool down. So some strategies for cooling down, like how do I cool down when I'm overheated or I'm too hot and I'm having symptoms? One is to remain in an air-conditioned environment. I always tell my patients to sleep in the coldest temperature that you can tolerate or what you feel like you can afford AC bill-wise, because I know in Texas and these hot states, our AC bills are pretty high in the summer. But some people don't know that if you do replace your air conditioner or you need a new air conditioner, it can be tax deductible if you have a prescription. So you can get a pretty good break on it if you need an updated system. The other one is to wear lightweight, very breathable clothing. So kind of that exercise material, that dry fit material, moisture wicking that a lot of these sports and activity stores sell, like Academy, Dick's, things like that. Using or wearing less layers as possible when it's warm and very breathable, loose clothing will help keep your temperature down. And the other thing is like our heat escapes our hands, feet, and our head. So if you're wearing turtlenecks or you're wearing a lot of layers, you are not allowing that heat to escape your body. Patients living with MS often don't sweat. And what sweat does is it helps you reduce your body temperature. So if you are unable to sweat, then it's really important that you utilize your clothing to your benefit. The other thing is to drink really cold water and even eat popsicles. That's just not limited to tonsil removal surgery. Anything that you can drink or eat that is cold will definitely have benefit and help you. If you are going to get in a pool and you're going to do aquatic exercise or pool exercise, it's important that it's less than 85 degrees, which sometimes it can be challenging to find a pool, but there are some resources. Like here in Dallas, we have a program that's just for persons living with MS where they keep the pool less than 85 degrees because they know too warm of water can make symptoms worse. And then again, try pre and post cooling. Drink that ice cold water before you work out and after you work out. If you need a bathroom nearby, then set it up. Because I have patients that don't want to drink water in therapy because they're afraid to go to the bathroom. And I'm like, if I have to sit you in a wheelchair and run you to the bathroom, I'm willing to do that just so you can keep your temperature down. And then the cooling vest, I have a ton of patients that wear cooling vest under their clothes and you can't even see them. And there's a lot of good resources through the MS Society, mymsaa.org, where you can even apply for a cooling vest to be donated to you. I can't talk about cooling vest enough for that concurrent cooling. So you don't even get to the point that you're combating being too hot. You just always stay at a tepid temperature.
And before I hop onto this, I think I just want to reiterate something Heather said. You know, you're not hurting yourself. You're not making your MS worse. Because oftentimes my patients will tell me, well, I'm afraid to go to my kid's baseball game in the summer. And I often tell them, if you want to go to the baseball game, go to the baseball game. You're not making your MS worse. It's a temporary phenomenon. And so I think that's really something important to acknowledge and remember is you're not making your disease worse. It is temporary. And the other thing is sometimes it's the cold. My patients who tell me, oh, the cold affects me more than the heat, I tell them, well, you didn't read the textbook, but that's okay. Because it happens. Often I see patients who tell me it's actually the cold. And so the reverse kind of strategies to stay warm may be important for you. And then we're kind of running out of time just in terms of getting to the Q&A. So just wanted to touch briefly on some other invisible symptoms that we didn't highlight, but are also common, just so we've acknowledged them. Vision symptoms. So often patients will tell me, you know, they don't drive at night because of their vision. And so that's something important to acknowledge. The bowel and the bladder, as Heather mentioned just now in her example, you know, patients will avoid things because they're worried about bowel and bladder changes. So this is another important thing to acknowledge. And then last but not least, and we've touched on it a ton, is sleep. It's huge. Sleep can be impacted by MS and sleep can be impacted by all of the symptoms of MS. And so it's important to really, really make sleep a priority. And I think that's it, right, Paige?
Awesome. Yeah, thank you. Yeah, we're gonna jump into the Q&A. We just got a ton of information and we could have gone on and on. I know Lauren and Heather have so much to talk about this topic. But let's jump to some of your questions. All right, so we got quite a few good questions here. Let's start with Heather. You talked about motion is the lotion, use it or you lose it. How do you balance exercising the right amount versus resting to make sure that you're not overdoing it?
So what I do is every patient that I see with this condition gets that formalized structured program, and we use something called an RPE scale, which is a rating of perceived exertion. And it's kind of, you can align it with the red, green, yellow light. And so when I give them an exercise and I give them reps or sets, I say, where are you on this spectrum? If they're in the yellow, that's right where I want you to be if you're living with MS. I want you to stay in the yellow. I want you to still be able to talk to me and feel like you have energy. If you're getting into the red or the green, I'm going to go down or up on my rep count. So that's why it has to be formalized and structured to where you do the exercise, you finish, and you can still do all of your activities of daily living without having to rest and take 2 to 3 hours. Now, if you're getting into that red zone, then maybe doing seated exercise instead of standing exercise is going to be the best for you to do that day. I have good and bad day exercise programs for my patients. So if you're having an MS day, which is what a lot of patients will describe to me, I'll say, here's your MS day exercises. And when you feel like you can move a little bit more, here's your other exercise program. That's why finding the right provider, I tell my patients, shop around. If you are with somebody and you don't like the care that you're giving, you don't have to stick with them. Find a new therapist, find a new provider. And so I think that's the take home message is find somebody who knows your green, red, and yellow lights and they structure your exercise around that.
That's great. And then with that, several folks have said that they haven't had any physical issues just quite yet, but should they still reach out to a PT and get somebody on their team?
Yes. Oh my gosh, please. Yes. I tell Lauren and the whole team over there, like day of diagnosis, please send them to therapy because we do what we call prophylactic intervention because range of motion loss and tightness and muscle strength loss are usually secondary and tertiary causes of immobility. And so we want to get you started on exercise program and lifestyle modifications to really try to stave off any physical limitations because the medication for MS is the best it's ever been right now. These MS meds, they're working. They are minimizing relapses. And so what you have left is really structuring your physical activity program. And if you don't know where to start, just the diagnosis of MS alone can get you in through insurance with a provider. You do not have to have a physical limitation to see a physical therapist.
That's great. I think this rolls into this next question as well. Somebody mentioned that they're newly diagnosed and not yet experiencing many or any of these symptoms quite yet. Should they wait to address these symptoms once they start to experience them, or is there something that people can do to prepare or even avoid some of these symptoms that we talked about? And that's for either of you.
Yeah,
Yeah.
I can take it from the
Okay,
non
yeah,
kind
yeah.
of physical manifestations. So, just because it's a potential symptom of multiple sclerosis doesn't mean that you're going to have it. And so I think it's important to acknowledge that the point of this is not to scare you into this is what's coming, because it may not be coming. As Heather mentioned, our treatments are really, really good. And so if we're on, a treatment that is working for you and we're not seeing disease progression, MRI changes, things like that, there's a chance, you may not. However, a lot of these things also just come with normal life. And so I think it's important to still screen for them. And really, that's kind of the role of your healthcare team is to be screening for these symptoms. And so, like in my visits, if a patient, sometimes patients will come with a list, but if they don't come with a list, I have my checklist that I'm going through each visit. Are you sleeping? How's your fatigue? How's your mood? And so it's really something that should be addressed regularly so we can catch it early if it is an issue. And then Heather, I know I cut you off, so I'll let you take over from there.
No, that's definitely helpful. So I was just looking at the comment box and somebody said, I saw somebody who's a specialist and they said they didn't know what to do with me. And so what I generally say to that, if I have somebody who I'm standing in front of that's living with MS that's in better shape than me, here's what I say. You need to get 10,000 steps a minimum a day. You need to be able to do 25 hill races on each leg. You need to be able to walk on your heels for any distance. Here's the balance exercises you need to do. I give them a screen that they can work through, and I have them see me every 6 months. That's the other thing. Therapy doesn't have to be 2 to 3 times a week forever. Lauren and team will send me patients and they'll write on their boot camp where I just see them for a week straight and I give them all the tools for what they can do at home. And I say, come back and see me if you have a new symptom. I might see a patient 1 or 2 times. Here's what to look for. Here's how you can combat this condition. Come back and see me. I always say when I pick up a patient with MS, I'm going to see them for a lifetime, but that might be once a year for a lifetime, and it might be once a week for a lifetime. You can literally start anywhere with anyone. So I just want to tell you, if somebody tells you I don't know what to do for you, respectfully, you need to see somebody else.
I love that. I love boot camp. That's awesome.
Yeah, boot camp.
You don't think about just going to see a PT just to gain the knowledge that
Yeah.
all you have.
Here's what to look out for. Here's the symptoms, like how to see the early signs of foot drop.
Absolutely. Lauren, we've got some questions about changing hormones and how they might affect some of these symptoms from the point of aging, menopause, and even just using hormonal supplements that were provided by healthcare professionals.
Yeah, it's a big thing we see, specifically kind of in perimenopause, where I'll see that patients have a worsening of their baseline symptoms, their cognition, their fatigue. And the question is really, is it MS or is it the changes that are occurring? Because those in themselves can manifest in those ways. But in my MS patients, it is 100% exacerbated. And I again, I think the important thing is to acknowledge that because a lot of times it gets kind of written off like, oh no, it's just normal. That's just part of life. But really in MS, it's a lot worse than just the normal things that we would normally experience in life. And so it's really exacerbated. In terms of like hormone replacement therapy and things like that, it's really an individualized conversation with your healthcare provider as well as the person who will be prescribing it. But I have patients who do and they feel better. And so it's really individualized because there's some reasons that patients can't go into hormone replacement therapy. There's safety related to that. And so it's really important to acknowledge risk benefit, and it's kind of a dual kind of process. I've worked with a lot of like the women's health providers, they'll call me to be like, what do you think about this? If my patient's asking for this, do you think it's okay? And in general, I'm not going to say no unless, there's other risk factors like stroke or things like that that we're also managing and treating. But it's a real phenomena. A lot of times I find that patients, once they get through that perimenopause phase, it usually kind of goes back to baseline is what I tend to see from my patients, at least what they tell me. And so, but it's important to acknowledge because I think a lot of times it gets blown off, which can be very disheartening.
Absolutely. And just from the words that you've used, and I'm seeing a lot of comments and questions about this, with all sorts of different symptoms, telling the difference between if my cognitive dysfunction, if my depression, so forth, is it normal aging or is it MS? Doesn't matter, or will we move forward the same way?
So I think it matters in the sense of acknowledging it, right? Your cognitive symptoms are related to your MS, especially if you're seeing something, let's say you have a peer who doesn't have MS, right? And you're like, I'm just like really struggling at work. And I think acknowledging it is important because again, I always tell my patients, you got to give yourself some grace. You've got to stop beating yourself up. You're already at a disadvantage because of MS, and then you throw aging on there as well. And so I think it is very hard to disentangle, but I think a lot of times these things are exacerbated by underlying multiple sclerosis. And so while we may not be able to disentangle it, the management is a lot of times very similar, although there are some MS specific things in terms of the heat management, the cognitive strategies. And so again, it's hard to disentangle. Sometimes the management overlaps, but I think it's important to acknowledge that what you're experiencing may be worse because you also have an MS as well as aging.
Absolutely, they definitely go hand in hand. All right, Heather, we've got some questions about nerve pain. Somebody says that they have had nerve pain for several years, and it can last for hours on a daily basis. They're already on several pain medications. Is this something that they're just going to have to live with and deal with? Or do you have a little extra for them to kind of work through some of that pain?
So I find that patients that have been on chronic pain management meds, your body kind of just tends to get used to it and it doesn't have the same effects. So I always say you got to trick your body. You can't do the same exercise forever and do the same results. You can't take the same medicine forever and expect different results, right? So I say, what haven't you tried? Have you tried TENS, which is a version of electrical stimulation? That can confuse your pain fibers into thinking, hey, I actually don't need to be this responsive all the time and this dramatic. And it can really try to mix up your signals and to reduce your pain. If you haven't tried acupuncture or massage therapy, if you have not tried the modalities, the hot, cold, or even interchanging them, those are new ways to introduce sensory experiences to really kind of confuse your nerves into being less responsive. And I'm not going to say that any of it's going to make your pain a 0 out of 0, but if you don't try something different, then you'll just be on the hamster wheel. And you, as a PT, I'm hardly ever going to say you should try a new medication because I want to help the body heal itself, right? So everything as a rehabilitation provider that I'm going to recommend are going to be things that you can do the day of that I talked to you about. And it's also going to be things that you may not have tried in a very long time, if at all. And TENS is a very great intervention that I recommend.
I think what you just said was really important of like, you might not have tried it for a long time. I've heard a lot of folks who say, hey, this didn't work for me, this didn't work for me, this didn't work for me. And then all of a sudden I tried it again and it did work. Like
Yeah.
Lauren was saying, hormonal changes, aging, all sorts of things change our bodies. So I think that's really
Sure.
important. I think we have time for at least one more question. Lauren, you talked a little bit about talking with your family and friends about these invisible symptoms. If someone in your family or friends just keep saying, you look so good, I don't understand. how do you sit down and start having like a real conversation with somebody about, hey, you might not be able to see this, but this is what I'm experiencing?
If you're up for it, bring them to your visit. I think that is a huge way to kind of introduce people to what's going on. So if it's someone very close to you that you're comfortable with coming to your visit with me or your healthcare provider, bring them so they can see that we discuss these things and these things are real. So I think that's an easy way. I think the other way is like I said earlier, is educating them. Direct them towards Can Do, direct them towards National MS Society, invite them to come to these programs where they see that there's 200 plus people here and we're talking about invisible symptoms, right? And so helping them just recognize that it's real, I think is huge.
That's a really great point. I think we have something really quick. We didn't touch a whole lot on spasticity. Heather, can you give us a quick, what is spasticity? And then somebody asked, does it get worse with time, over time, and can physical therapy help with spasticity?
So spasticity is basically the best way to describe it is resistant to movement or resistant to stretch. And it is generally caused directly related to those central nervous system issues that we were talking about in the brain or the spine. Now, I know I said that I don't really recommend medication, but sometimes spasticity management I will talk to Lauren about and the other medical providers. There's two, so stretching can really help and keeping the muscles loose and working on your range of motion, that can always help, but it's usually temporary. Where we use medicine as a supplement is to really remediate long-term causes of spasticity and their limitations. And so I do want Lauren to talk about spasticity a little bit. From my perspective, I like to get patients on a really good range of motion and stretching program. I also use electrical stimulation for anti-spasticity tactics, and it can actually be very effective. You have to do it for several hours a day, but patients find a lot of relief from that tone and spasticity. And then in terms of progression and things like that, I'll hand it over to you, Lauren.
Yeah, first to highlight something Heather said, she said, I'll send Lauren and team a message. And that is so true. And so I think a big piece of spasticity management of all of this is if you can, and it's not possible for everyone, just depending on where you live, but if you live in an area that has, a center of excellence, a multidisciplinary type setup, having the team communicate is huge because I can't tell you how many times Heather or some of her colleagues have sent me a message and be like, hey, Lauren, I think you need to put this patient on XYZ. I think they would be much better at therapy if you address this better. And so it's huge and it helps and it's great for patient care. In terms of like the progression of spasticity, so we can see it progress over time. It kind of varies on where we're seeing it. If there's limitations in mobility, patients can get contractures over time. And so that's why it's really important to also continue to work on spasticity and to see therapists often. A lot of times I'll do yearly check-ins. Let's go back next year. Your insurance is up, but we'll reset in January and we'll go back and just check in to keep making sure we're keeping those muscles active because it can progress. And then in terms of the management, there's a lot of different ways to manage it. So if I have a patient who just has, in general spasticity, oral medications can be great for that. If I've got a patient who just has, an arm or a leg or one muscle group, there's injections that can be given to really target that. And so there's a lot of different modalities to manage spasticity. And a lot of times I'll work with our PM&R doctors, so our physical medicine and rehab doctors. If it's someone that they're kind of beyond I've tried what I know, let me get you to the spasticity expert who's better at kind of the focal management or the individualized muscle group management.
Well, you ladies are great. Everyone's going to want you on their care team for sure. So thank you for you two for answering all these great questions and diving into all these important topics. As always, please connect with us on our socials. We provide extra resources and heads up on more programs coming down the pipeline. So make sure you get onto our socials. We also just want to thank our sponsors one more time, the Kathleen C. Moore Foundation and Novartis. Thank you. And Lauren and Heather, one more time, thank you so much for coming with us today. I hope everyone learned a lot. I know I did. So have a great night, everyone.